Sacrocolpopexy is considered the gold standard in treating apical pelvic organ prolapse. Also, it can be combined with rectopexy when treating multi-compartment prolapse. The aim of our study was to assess the safety and the effectiveness of laparoscopic sacrocolpopexy and sacrocolporectopexy in a population-based cohort. The population of our study is part of FINPOP cohort, which comprises 3,500 prolapse operations done in Finland during 2015. There were 154 sacrocolpopexies and 72 sacrocolporectopexies. Outcomes were serious complications up to 1 year, change in PFDI-20 score and its subscales at 6 and 24 months, patient global impression of improvement, and patient acceptable symptom state. These two groups differed from each other at baseline. There were more prior prolapse surgery and hysterectomies in the sacrocolpopexy group. Advanced apical prolapse was more common among sacrocolpopexy group, whereas advanced posterior compartment prolapse was more common among sacrocolporectopexy patients. Also, the symptom bother was greater among sacrocolporectopexy patients. Thus, we have not done intergroup comparisons. And concomitant vaginal repair was rare, and there were no anti-incontinence surgeries. Serious morbidity up to 12 months was low, and it was comparable between the groups. The mean PFDI-20 score decreased in both groups significantly, and the decrease was greater than the minimal important difference. Also, the three subscales, that is bulge-related symptoms, defecation-related symptoms, and bladder-related symptoms, improved significantly in both groups. 86% of the patients in sacrocolpopexy group and 58% of the patients in sacrocolporectopexy group considered their stage very much better or much better at 2 years. 90% of the patients in sacrocolpopexy group and 69% of the patients in sacrocolporectopexy group considered that they were good enough at 2 years. In conclusion, laparoscopic sacrocolpopexy and sacrocolporectopexy reduce pelvic floor-related symptoms effectively. Most women experience subjective global improvement. Women undergoing sacrocolporectopexy start with worse symptoms and also improve and achieve patient-acceptable symptom state less often. Whether this is operation or condition-related can't be answered based on our study. Thank you.
Now, did a urogynecologist perform the sacrocolporectopexy, or was it conjoined with an abdominal surgeon?
Mainly gynecologists.
Only a?
Yeah, there were maybe two, or some were accompanied with colorectal surgeons, but most of them were done by gynecologists.
Thank you for the nice presentation. Elias Yarenis from Norwich. I was wondering, which was the indication for the rectopexy?
Yeah, can I get the slides back? I think it was 80% of the times there was intussusception, and then the rest of them, I don't have the answer for that, but I assume that in some institutes it is sort of always done in a standardized way, so that even the rectum is sort of, there are some sutures put to rectum as well.
My second question, in the sacrocolporectopexy group, when you see the PGI-I, the very much better and much better group was quite low, so it was in the 60s. How would you describe a 40% what we could see in the failure?
Yes, exactly. This is sort of interesting finding, and I think this should be sort of addressed in future studies.
I think probably you have to go back and see the indication in your practice of doing the
Yes.
rectopexy.
These are results from 20 hospitals, and there are a lot of differences between the institutes, how they perform things. This is a national cohort.
Thank you.
Costantini from Italy. If I understand well, these two groups of patients are different. And I think that, I don't know if they are comparable, but the other question is, which is the difference in the surgical technique? So in sacrocolpopexy, do you put two meshes fixed to the vagina or elevator honey? And in the sacrocolporectopexy, you position only one anterior and one on the rectum? Can you?
Well, as I told, this is from 20 different hospitals, national-based cohort, and we did not specify the technique. In my institute, we always go to the levator ani level, attach the bottom part to the muscle, but I don't know about the other institutions.
So
We didn't specify.
I think that it's interesting, and it's an interesting study, because we don't know when we perform sacrocolpopexy if we are able to correct some kind of fecal problems and constipations and so on. But the problem is that you should have comparable groups, because
Of course.
otherwise we are not able
Yes.
to understand how the procedure works in different patients.
I agree. I completely agree.
Hello, Yukila from Germany. Thanks for the presentation. Actually, since you're saying that there are different techniques being applied, did some of the centers included in the study use a sleeve rectopexy as part of the procedure? Or was it always that the rectum was just attached to the posterior leaf of the mesh that goes just downward to the levator ani?
Yeah, we have not specified the technique, but my assumption is that it was so that it was just attached with sutures to the rectum as well, like 3 pairs of sutures.
So no classic sleeve rectopexy was performed in some of these patients?
I don't know what that is, but no, I don't. What is that?
That you put a sleeve around the rectum, and when you go with the preparation, you just take the rectum completely off the anterior sacral wall and have a sleeve around it and drag it upward.
These are anterior ventral rectopexy.
I see. And maybe you give us a glance about the operation time, whether it was mainly different between the two groups.
Oh, actually, I can't remember that. I think there was not big difference.
Okay,
but
thank you
I
very
don't know.
much.
Yeah. Thank you.
Thank you.